Welcome to the Deep Dive. Today we're tackling a condition you might have heard about, especially if you have a dog maybe getting a bit older. Cushing's disease.
That's right, hyperadrenocorticism, to use the technical term.
Right. We've gone through quite a bit of information to sort of pull together a clear picture of what this is all about.
Exactly. And our mission today is really to give you, the listener, a solid understanding of Cushing's in pets. We'll focus mostly on dogs because, honestly, it's much, much more common in dogs than cats.
Okay.
We want to cover, the causes, the signs you might see, how vets figure it out, and what can be done about it, hopefully without making it too overwhelming.
Sounds good. So maybe let's start right at the beginning. Fundamentally, what is Cushing's disease? What's actually happening inside the dog's body?
Okay, so at its core, Cushing's disease is all about the adrenal glands producing way too much cortisol.
Cortisol, that's the stress hormone, right?
Yeah, exactly. It does a lot of important things in the body, but like with most things, too much of it causes problems. Big problems sometimes.
And how does that happen? Does it just start spontaneously?
Well, there are two main ways it happens spontaneously, yes. And then there's the third way. It can be caused by external factors.
Okay, let's break those down, the spontaneous ones first.
Sure. The two main players are pituitary-dependent hyperadrenocorticism. We usually just call it PDH, and adrenal-dependent hyperadrenocorticism, or ADH.
PDH and ADH. Got it.
And we should also quickly mention iatrogenic Cushing's. That name kind of gives it away. It's caused by medical treatment.
Okay. We'll come back to that one. Let's start with the most common, you said. PDH.
Yes, PDH is definitely the one we see most often. It accounts for, something like 85 to 90% of all spontaneous Cushing's cases in dogs.
Wow. Okay, so what's going wrong in PDH?
Usually the problem starts with a tiny benign tumor and adenoma on the pituitary gland.
The pituitary. That's the gland at the base of the brain, right? The master gland.
That's the one. Tiny but mighty. This little tumor causes the pituitary to go into overdrive, pumping out way too much of another hormone called ACTH, adrenocorticotropic hormone.
ACTH. Okay, and what does ACTH normally do?
ACTH is basically the messenger hormone. It travels from the pituitary down to the adrenal glands, which sit near the kidneys, and tells them, okay, make some cortisol.
Right.
So with PDH, you've got this constant flood of ACTH hitting the adrenal glands. They just keep getting the message, make more cortisol. Make more cortisol.
So the adrenals themselves are actually working fine. They're just getting bad instructions from upstairs, so to speak.
Exactly. The control center, the pituitary, is sending out way too many production orders.
Okay, that makes sense. Now, what about the other spontaneous type, ADH? Adrenal dependent.
Right, ADH. This is the less common scenario, maybe 10 to 15% of cases. Here, the pituitary gland is usually behaving itself.
So the problem's not the signals.
No. The problem originates directly within one of the adrenal glands. There's a tumor on the adrenal gland itself.
Okay.
And this tumor, whether it's benign an adenoma or, unfortunately, sometimes malignant a carcinoma, it just starts churning out massive amounts of cortisol all on its own.
So it doesn't need the ACTH signal from the pituitary anymore. It's just gone rogue.
Precisely. It's acting autonomously. The normal feedback loops don't work. It's like a factory floor ignoring the head office completely.
Gotcha. Okay, and then you mentioned the third type, iatrogenic.
Yes, iatrogenic Cushing's. This isn't the dog's body spontaneously malfunctioning. It's a side effect of medication.
What kind of medication?
Specifically, long-term use of corticosteroid drugs. Things like prednisone are the most common examples.
Steroids. Vets prescribe those for lots of things, like allergies or inflammation, right?
Exactly. They're incredibly useful drugs, but they mimic the body's own cortisol. So if a dog is on high doses or is on them for a very long time,
The body basically ends up with too much cortisol effect, just like in the natural disease.
that's it. The symptoms can look identical. That's why the dog's medication history is so important when we're diagnosing.
Makes sense. Okay, so we know the what and the why. What about the who? Are certain dogs more likely to get Cushing's?
It's definitely a dog disease primarily. Very rare in cats.
Okay.
Yeah, and yes, some breeds do seem to pop up more often. We see it quite a bit in poodles, especially miniature poodles, dachshunds, boxers, beagles, and several terrier breeds seem predisposed too.
Interesting. Any particular age group? You mentioned older dogs earlier.
Yes, typically it's a condition of middle-aged to older dogs. Generally 6 years old and up is the classic time frame when we start seeing it diagnosed.
And does gender matter?
There seems to be a slight tendency for it to be diagnosed a bit more often in female dogs, but it definitely occurs in males too.
Okay. So middle-aged to older dogs, certain breeds may be more at risk. Now, the really practical bit for owners. What signs should they be watching for? What are the clues?
There are some pretty classic signs, though not every dog shows all of them, of course. Probably the most common things owners notice first are increased thirst and urination.
The PUPD we hear about?
Exactly, polyuria and polydipsia. Your dog might suddenly be glued to the water bowl, drinking way more than usual.
And needing to go out constantly, maybe having accidents inside.
Yes, precisely. That follows naturally from drinking so much. Another really common one is increased appetite polyphagia.
So the dog seems ravenous all the time, always begging for food,
Yeah, they can become quite food obsessed. Then there's often increased panting.
even when they're not hot or haven't been exercising.
Right. Just panting while resting.
Yeah.
It'd be quite noticeable.
Okay. What about physical changes? I've heard about a pot-bellied look.
Ah, yes, the classic potbelly. Abdominal distension is very common. It's usually a combination of muscle weakness in the abdominal wall and fat getting redistributed into the abdomen. It can make them look quite round in the middle, almost like they've swallowed a basketball sometimes.
And other physical signs. Skin and coat?
Definitely. Hair loss is a big one. We call it bilaterally symmetrical alopecia.
Meaning it's even on both sides of the body.
Yeah, typically on the flanks, the main body area.
Yeah.
And crucially, it's often not itchy hair loss, which helps distinguish it from things like allergies. The skin itself can become quite thin, almost fragile sometimes. You might notice it bruises easily, or wounds seem to take forever to heal. Some dogs also develop muscle weakness or muscle wasting, so they might seem generally weaker, more lethargic, maybe have trouble jumping up or going upstairs.
That sounds quite debilitating.
It can be. And in some cases, you might see hard, gritty plaques forming in the skin that's called calcinosis cutis, calcium deposits.
Wow. Anything else?
Well, because all that excess cortisol suppresses the immune system.
Ah, so they might get infections more easily.
Exactly. Recurrent skin infections, urinary tract infections, UTIs are quite common complications because their defenses are down.
Okay, so that's quite a list of potential signs. If an owner sees a few of these things lining up, what happens next? How does the vet actually confirm if it is Cushing's? Sounds like it could mimic other things, too.
It absolutely can, and that's why diagnosis isn't always simple. It's rarely just one test. It's about piecing together the puzzle, the dog's history, those clinical signs, the owner reports, physical exam findings, and then, yes, specific lab tests.
What kind of initial lab tests give clues? Blood work, urine tests?
Both are really important starting points. On a complete blood count, the CBC, we might see something called a stress leukogram.
Stress, leukogram, what does that mean?
It's just a characteristic pattern of changes in the white blood cell counts. Certain types go up, others go down. That often happens when the body's under chronic stress, like from high cortisol.
Okay.
Then on the serum chemistry panel, the blood test that looks at organ function and other levels, we often see some key changes. A very common one is an elevated ALP, alkaline phosphatase.
ALP, why does that go up?
High cortisol affects the liver. It causes a specific change we sometimes call steroid-induced hepatopathy. The elevated ALP is a marker of that effect.
Got it. Any other chemistry changes?
Yeah, we often see high cholesterol, hypercholesterolemia,
Mm-hmm.
and sometimes elevated blood glucose, hyperglycemia.
High blood sugar. Could that be confused with diabetes?
It can. And sometimes Cushing's can actually trigger or worsen diabetes because cortisol interferes with insulin. So that's something vets are definitely looking at closely.
Okay. What about the urine? What clues are in there?
The urinalysis is helpful too. We often see dilute urine, a low urine-specific gravity. That fits with the excessive drinking. The kitties just can't concentrate the urine well.
Right.
We might also find protein in the urine, proteinuria. And as we mentioned, we'll be checking carefully for any signs of a urinary tract infection, since those are common.
So these initial tests provide strong hints, but they don't definitively say Cushing's, right? What are the specific tests for that?
Exactly. Those are supportive findings. To really screen for Cushing's, we move to specific hormonal tests. The main ones are the low-dose dexamethasone suppression test, the LDDST, and the ACTH stimulation test.
Okay, the LDDST first. How does that work?
So dexamethasone is a synthetic cortisol-like drug. In the LDDST, we give the dog a very small, measured dose.
Okay.
In a normal dog, that tiny bit of dexamethasone should signal the pituitary gland to say, whoa, there's enough cortisol around, stop sending ACTH. And cortisol production should drop or be suppressed.
But in a dog with Cushing's?
In most dogs with Cushing's, either PDH or ADH, that suppression doesn't happen properly. Their cortisol levels stay high even after the dexamethasone. It's generally considered the most sensitive screening test, meaning it's good at picking up cases.
Gotcha. And the ACTH stimulation test.
For this one, we measure a baseline cortisol level first. Then we inject synthetic ACTH, that hormone that tells the adrenals to produce cortisol.
Right, giving them the go signal.
Exactly. We then measure the cortisol level again after about an hour. In a normal dog, cortisol will rise, but only to a certain level. In a dog with Cushing's, their already overactive adrenal glands tend to hyperrespond, producing a really exaggerated high level of cortisol after the stimulation.
So one test sees if you can turn it off, LDDST. The other sees how much you can turn it on, ACTH stim.
That's a great way to think about it, yeah. The ACTH stim isn't quite as sensitive as the LDDST for catching all cases, but it's very useful, especially for confirming the diagnosis, and that's the main test used to monitor treatment later on. It's also particularly helpful if we suspect iatrogenic Cushing's.
Why is that?
Because if a dog has iatrogenic Cushing's from long-term steroid pills, their own adrenal glands actually shrink and become lazy because the body's getting cortisol from the pills. So if you give them ACTH, they won't have an exaggerated response. They might even have a very low response.
Ah, interesting distinction. Is there a urine test for screening, too?
There is the urine cortisol-creatinine ratio, or UCCR. You collect a urine sample, usually first thing in the morning at home, to minimize stress and measure cortisol relative to creatinine, a waste product.
How useful is that one?
It's very sensitive. So if the UCCR is normal, it makes Cushing's very unlikely. It's good for ruling it out.
But if it's high?
Ah, that's the catch. It's not very specific. Lots of things. Besides Cushing's, any kind of stress or illness can raise urine cortisol. So a high result doesn't confirm Cushing's. It just means you need to do more testing, like the LDDST or ACTH stim.
Okay, so let's say the screening tests point towards Cushing's. How do you then figure out which type it is, the pituitary PDH or the adrenal ADH kind? Because treatment might differ, right?
Exactly. That differentiation is crucial. We have a few tools for that. Sometimes the LDDST itself can give clues based on the pattern of suppression, but it's not always definitive.
What else?
The high-dose dexamethasone suppression test, HDDST, can sometimes help. It's similar to the low-dose test, but uses a much higher dose of dexamethasone.
And the idea is?
The theory is that some pituitary tumors, PDH, might still respond slightly to that very high dose and show some cortisol suppression, whereas adrenal tumors, ADH, which are acting completely independently, usually won't suppress at all, no matter how high the dexamethasone dose. It helps, but again, it's not foolproof.
Are there blood tests that help differentiate?
Yes. Measuring the dog's own ACTH level, endogenous ACTH, can be very helpful.
How so?
Remember, in ADH, the adrenal tumor is pumping out cortisol, which tells the pituitary to shut down ACTH production. So dogs with ADH typically have very low, often undetectable ACTH levels.
Okay.
But in PDH, the pituitary tumor is the source of the problem, often making too much ACTH, or at least not responding to feedback. So dogs with PDH usually have normal or even high ACTH levels.
That sounds like a pretty clear difference.
It often is, yes. It's a very useful differentiating test.
And what about actually seeing the problem? Imaging.
Imaging is super important, especially for differentiating and planning treatment. Abdominal ultrasound is key.
What can you see on ultrasound?
We can look directly at both adrenal glands. In ADH, we're hoping to find one adrenal gland that's enlarged, maybe has a visible tumor, while the other adrenal gland might actually be small because it's not getting much ACTH stimulation.
Ah, because the tumorous one is suppressing ACTH for both.
Exactly. Whereas in PDH, where both adrenals are being overstimulated by pituitary ACTH, we often see both adrenal glands looking plump or enlarged.
So ultrasound gives strong clues about the location.
Definitely. And it's essential if you're considering surgery for an adrenal tumor. For looking at the pituitary gland itself, though, you usually need more advanced imaging.
Like MRI or CT scans.
Yes. MRI is generally preferred for visualizing the brain and pituitary gland to look for those pituitary adenomas. CT can also be used. This is especially important if the dog is showing neurological signs.
Okay, so you've done the detective work, you have a diagnosis, if it's PDH or ADH. What are the treatment paths?
It really depends on the type, like you said, and the individual dog. For PDH, the most common form, medical management, is usually the way to go.
Using medications, which ones?
The main drug used nowadays is trilostane.
Trilostane, how does that work?
It works inside the adrenal glands to inhibit one of the key enzymes needed to produce cortisol. So it effectively slows down cortisol production without actually destroying the gland tissue.
So it manages the symptoms by reducing cortisol.
Exactly. It requires careful monitoring and dose adjustments, usually for the rest of the dog's life, but it can be very effective at controlling the signs of Cushing's.
Is that the only medication?
There's another older drug called mitotane, or OPDDD. This one is actually selectively toxic to the cortisol-producing parts of the adrenal gland. It gradually destroys them.
That sounds more permanent.
It can be, but it also carries a higher risk of side effects, like causing cortisol levels to drop too low, hypoadrenocorticism or Addison's disease, so it needs extremely careful management. It's used less often now that trilostane is available. There are a couple of other drugs like ketoconazole or selegiline, but they're generally considered less effective or used in specific situations.
Okay, so mostly medication for PDH. What about surgery? You mentioned adrenal tumors for ADH.
Right. For ADH, if the ultrasound shows a tumor on one adrenal gland and the dog is otherwise a good candidate, surgery to remove that affected adrenal gland in adrenalectomy is often the treatment of choice.
Can that cure it?
If the tumor is benign, an adenoma, and it's removed completely, yes, surgery can be curative. If it's a malignant tumor, a carcinoma, surgery might still be done, but the prognosis is more guarded. It's a major surgery, though, definitely not routine.
Any surgery for the pituitary type, PDH?
There's a procedure called hypophysectomy, which is surgically removing the pituitary tumor. But it's a very specialized, complex brain surgery, only performed at a few centers worldwide. So, not a common option.
And I think you mentioned radiation earlier.
Yes, radiation therapy is sometimes considered for pituitary tumors, particularly if they're large, what we call macrodenomas, and are causing neurological problems by pressing on the brain. It aims to shrink the tumor or stop its growth.
Okay, so with these treatments, what's the general outlook, the prognosis?
For PDH managed with medication like trilostane, the prognosis is generally good for quality of life. The goal is controlling the symptoms. It's management, not usually a cure, and requires lifelong commitment from the owner for medication and monitoring.
But they can live well for quite some time.
Yes, absolutely. Many dogs live happily for years with well-managed PDH. For ADH, it really hinges on the tumor type.
Benign versus malignant.
Exactly. Benign tumor removed successfully. Prognosis can be excellent, potentially cured. Malignant tumor. The outlook is much more guarded, depending on if it has spread.
Are there any long-term complications of Cushing's itself, even if it's being treated, things owners should still watch for?
Yes, definitely. Hypertension, high blood pressure is common, so that needs monitoring. We already mentioned the increased risk of urinary tract infections due to the immune suppression.
Right.
And the link with diabetes mellitus is important too. The high cortisol can cause insulin resistance, making diabetes more likely or harder to control if the dog already has it. So monitoring for signs of diabetes is also key.
Okay. Wow, we've covered a lot of ground there. So just to kind of wrap things up, what are the absolute key takeaways for someone listening?
I'd say the big things are Cushing's means too much cortisol, usually from a pituitary issue, PDH, or an adrenal tumor, ADH, sometimes from steroid meds. Watch for those key signs: heavy drinking and peeing, huge appetite, pot belly, skin changes, hair loss. Diagnosis takes detective work history, signs, blood tests, urine tests, and specific hormone tests like LDDST or ACTH-STIM, then maybe imaging or ACTH levels to pinpoint the cause.
And treatment depends on the cause. Usually meds like trilostane for PDH, maybe surgery for ADH. Prognosis varies, but can be good with management.
Exactly. The outlook often depends heavily on the underlying cause and catching it early enough.
And I guess the main message for you listening is know those signs. If your dog, especially an older one, starts showing that cluster of symptoms, the drinking, the peeing, the appetite, the belly, the panting, the skin issues, don't just put it down old age. Get it checked out by your vet.
Absolutely. Early diagnosis and proper management can make a huge difference to their comfort and quality of life.
It really makes you think, doesn't it? Seeing how these hormone imbalances, triggered by stress or internal issues, impact our pets so significantly. It kind of begs the question, what broader lessons can we learn from conditions like Cushing's about the long-term effects of stress and physiological dysregulation, maybe even thinking about other species, including ourselves?
That's a really interesting thought to end on. The interconnectedness of these systems is fascinating and maybe holds more insights than we realize. Definitely food for thought.